Well, welcome everybody to today's webinar. We're just getting things set up for the recording, and I'll let our speaker, Karen Forrest, and introduce yourself here in just a second. Just a couple of housekeeping items before we get started. If you need to ask a question during the presentation, use the chat feature, which is found on the right side of your screen. We will be offering one CEU, so if you would like that, please stick around to the very end. We'll have a code that's given. And just as a reminder, this webinar is being recorded, and we will upload this presentation to our website. And I'm going to go ahead and turn it over to our speaker and let her introduce herself.
So happy Monday, and thanks for joining us at noon for a talk on the medical evaluation of sexual abuse. My name is Karen Forrest. I'm one of the child abuse pediatricians employed by UAMS Department of Pediatrics, but I work at Children's Hospital, and I have the good fortune to have quite a bit of connection to the CACs across the state with the medical providers. I do see a couple of medical provider names on here, so hello to you guys. But the talk is actually not a medical talk per se. I'm not going to try to teach people how to do the medical exam, but I do want to talk just a little bit about which kids benefit from having an exam, and I will explain just a little bit about how we do the exams, not because I would expect you guys to go do them, but just so that you would understand if kids are being referred, what they should expect, and after they've had one, also what kind of information would we gain from having the exams. And then a big topic to hopefully make sure everybody is on the same page after we're done is for people to be able to understand the fact that it's actually normal to have a normal exam even if you have been sexually abused. And so we'll talk quite a bit about why there's oftentimes not physical evidence in these cases. And I'm probably talking to a group that already knows much of the background of this, but a big thing to understand as we're talking about child sexual abuse is some of the dynamics that are different in this versus the sexual assault of kind of teens and adults of what you might think of more as date rape or stranger rape. And this is not to say that child sexual abuse doesn't ever involve violent acts, but for the most part, child sexual abuse involves contact where the offender is actually known to the child, and they use that relationship in a way to really build and kind of build upon acts and allow this to continue to happen over a period of time because the child is either manipulated into not being able to tell or they are coerced into it. And so the topic that you'll hear, or the word that you'll hear used is grooming, which just means that they start with something kind of small in a relationship and then build that up over time. So that's actually a really big reason why we oftentimes don't have physical findings, because number one, these don't tend to be violent types of an event, but they're also very typically is delay in disclosure of these events where disclosure can be delayed for years, and we know from the literature that many folks never disclose what's happened. So this difference in dynamic is actually a really big thing to understand as you talk with folks at your MDT level about the fact why there's not usually findings and why the delays in disclosure are actually common things, and it doesn't mean that the child is not telling the truth just because they didn't tell right when it first happened. So if there's been an allegation of sexual abuse, the information that we need to try to decide whether or not an exam needs to be done and where it might need to be done is really the type of contact that's occurred, and typically we'll talk about the offender's body parts contacting the patient's body parts, and so the genital area to what part of the patient and the digital to what part. So this helps us understand, number one, is if there can be an opportunity to collect DNA evidence, but it can also help us understand what types of testing we might need to do for sexually transmitted infections. So we don't necessarily need a big in-depth forensic interview type of information right up front, but we do need to have kind of just some basic medical information to know if it's an exam that needs to happen right away and really kind of the depth of the exam that needs to occur. The general timing rule that we stick by is if the time of contact has been within the last 72 hours, and if the contact was to the point that it may have left behind some DNA material, such as semen or saliva or something like that, then those are the cases that might benefit from having an evidence collection kit collected. And so those kind of less than 72-hour cases are the ones that have the most urgency to be done quickly. If it's more than 72 hours out, and if there has really not been the type of contact we would expect to leave DNA evidence behind, then there's really not a huge urgency to have those exams done, and they should really wait until there is someone available to do the exam that kind of knows what they're doing, is comfortable with it, and will really kind of provide an accurate report with information not only to the family but to the investigators that are involved as well. So who needs an exam? We've talked a little bit about this, but if there is a chance to collect DNA evidence, then we definitely want to try to collect things within that window. So if there is DNA evidence recovered, it's obviously very, very helpful to the investigative side of the case. And many times when DNA evidence is recovered, there still aren't physical findings of injury. So if we can collect that, it's really important. The truth of the matter is we oftentimes don't get these cases until the 72-hour window has lapsed, and so oftentimes we don't even have the opportunity to collect DNA evidence. The other kids that benefit from an exam is if there has been a history of penile penetration at any site, so of the mouth, the genital area, or the anus, because those are sites that we could test for sexually transmitted infections. And if it's a girl that's already started to have her menses, then we might want to test to make sure that they're not pregnant. And then especially if the patient has described that there was either pain or bleeding when the contact occurred, then that could indicate that there would be residual injury for us to see on the exam. And I know this discussion comes up quite a bit with the MDTs across the state as far as really kind of wanting a list as far as kind of who needs an exam and who doesn't. And so the top 3 things, or really the top 4 things on that list, are the ones that really should be referred for an exam. There's not really anybody that I would say wouldn't benefit from an exam, because if there's a concern or if we feel like that there may still be more history that hasn't come out yet, the exams themselves, as we talk through this, really are not invasive or painful. And so there's not really a time where I would say that the child just shouldn't have an exam at all. But the top 4 things on the list are probably the ones that are the most important as far as really encouraging the families to follow through for an exam. For those of you that are familiar with the Children's Advocacy Centers and their accrediting body, the National Children's Alliance, their kind of statement as far as exams is that everybody that's been sexually abused should be offered an exam. So there's kind of a triage as far as who really needs one, but then the all should be offered is really kind of the standard from a national level. So most of the exams will fall into this category as being non-urgent. So non-urgent means the last contact has been more than 72 hours, or the patient's really not having urgent symptoms that we have to do it right away. At Children's, we have people sent to us from all over the state, and it's really frustrating to me for families that they'll show up on Saturday night at 2 o'clock in the morning and say that their local police have told them to come to Children's for an exam, and when you take the history, the last contact was 2 weeks ago, and the child's not really having any symptoms. So there's no reason for them to come to the ER at 2 o'clock in the morning. Those types of situations can definitely be held until either there's an appointment available somewhere, if they're close to a CAC that has medical services available, then that's going to be better. It's obviously less travel and stress on the child, and the cases that come through the ER here are kind of in line with everything else from car wrecks and the flu to different things, and so it can end up being really kind of a long and trying experience to have to wait for one of these exams in the ER. And a lot of times we'll have families even self-refer, so they come to the ER and say, my child just said that something happened. And so there seems to be like, this pressure that they want somebody to look and to see if it really happened. And we're going to spend quite a bit of time talking about the fact that the exam is actually not where the bulk of the information typically lies. And so we spend a lot of time talking with families about the fact that the exam is not really going to help them understand if the child's telling the truth or not. But it does give us an opportunity to make a hotline report and get the right people involved so that they can have a forensic interview and have the rest of the stuff that they need to find out what's happened. So the National Children's Alliance, besides kind of having their statement about who needs to be referred for an exam, they have standards that the CACs have to meet if they want to be accredited by the National Children's Alliance, and one of those standards is the medical standard. So the things that are kind of most important in the medical standard is that it does set a minimum amount of training that a medical provider has to have to do these exams, and that's regardless of whether you're a nurse or a physician or a physician assistant. None of us receive special training in child abuse during our kind of basic training time, and so for any of us that want to do these exams in a CAC or in a clinic that's specific to child abuse issues needs to have specific training for that. And then beyond the specific basic training, there needs to be continuing education as well that's specific to child abuse issues so that you can stay current in the field. So one of the big things in the medical standard is that the findings on the exam are supposed to be photo documented. And this, I think, can make some people feel uncomfortable because we're taking pictures of kind of the sensitive parts of kids' bodies, but there's actually some really good science behind why these need to be photo documented, because it is, for the medical providers, we're kind of like everybody else in these cases. We want to be helpful in these cases, and so if there are findings there, then we want to be able to describe those because then it helps the child be safe, it helps people be held accountable. But there's a huge tendency for us as helpers to actually overcall findings that maybe it doesn't look quite as normal as a textbook picture does, but there's actually a fairly defined list of findings on the exam that are considered either abnormal or not really specific for trauma. And if we don't photo document the findings and then have those available for either peer review, if it's a finding that we think is significant and might be used in court, but then also if we just have something that we're not sure about. So if we have it photo documented, we can have it reviewed without having the child have to go through multiple different examinations. We have had cases where kids do have a finding that does kind of show that they've had some type of genital trauma. And so when that case comes up from a court standpoint, again, those photos can be made available to the defense or other people for review without having to subject the child to having multiple examinations if somebody wants to contest what we thought was a significant finding. So that's probably one of the most difficult things for the providers out in the children's advocacy centers because it does take very specific equipment to be able to do photo documentation of the exam findings. And so if somebody's setting up a medical program, that's oftentimes one of their biggest hurdles would be to find a system that would allow them to photo document in a way that allows for people to interpret the findings off of there. And in Arkansas, this is actually probably not totally current because I don't have the satellite centers listed on here, but the CACs that have some sort of medical coverage on site are listed over there on the left side. Some of these do actually have 24/7 coverage of medical exams, and some just have people available on contract where they may be working their other job when a call for an exam comes in, and so they may not have somebody truly available 24/7. But then the ones that are referred, that right-hand column, the Little Rock Center deserves a little bit of an asterisk because we do the clinic here on the Children's Hospital campus does their exams, and so we actually are on campus with them. We're just not co-located on site with them. The West Memphis Center and the Jonesboro Center and the Arkadelphia Center are all working actively right now to recruit people to be able to do medical exams on site. So this is kind of an ever-changing list. And then there are some satellites going up in Monroe County and in Mena and I think in Nashville. And so there are other sites out there that hopefully will continue to grow access to this specialized service around the state. We've touched on this just a little bit, but this will come up oftentimes when we're talking about the type of history that we need to be able to perform the medical exam. And most of you are probably familiar with the forensic interview as far as kind of that in-depth interview that happens in collaboration with the investigators and sometimes DHS and whoever is kind of trained to do the forensic interview. But even if a child has had a real in-depth forensic interview, we oftentimes do need a little bit of additional medical history in order to do the type of evaluation that we need to do. So, number one, if the summary of information from the forensic interview can be made available to the medical provider, that can oftentimes cut down on the amount of information that we need to ask the family for the medical history. But I think it's also important that for people to understand that if we're asking a family additional history, that we're not really duplicating the forensic interview. We may need to know things about their past medical history or what's been going on with their body to try to help understand whether or not they need referred for some additional services or if they need some type of medical treatment. The biggest thing in the standard from the National Children's Alliance is it just really says that whatever process is in place for your MDT in your area, there needs to be something kind of in place to decrease the amount of duplication of interview time. So if somebody has a forensic interview and that information is not shared with whoever does the medical exam, then that's going to lead to a point where duplicate questions would have to be answered. But if there can be a kind of a flow of information both ways, then that will hopefully decrease the amount of duplication, even though each of those providers will need some specific history that they may need to ask on their own. I don't think that comes up a lot in Arkansas. I hear on a national level a lot of times that the medical providers have been told that they're not allowed to talk to the kids, and so that's really kind of not true. It's just really that we're supposed to avoid the duplication of the interview process. So as we kind of get into the exam itself, one of the biggest, I think, misconceptions and fears from families when they come to us for clinic exams is that they think that we're actually going to do a kind of a grown-up type of female exam on their young child, especially their young girl. And so that's really the first thing I can kind of see in people's eyes is they think that we're going to, on the 3-year-old, do what we would think of as a Pap Smear Exam on them. And I'll actually tell them that straight up, is that we're not doing a grown-up female exam on your child, and I'll make sure that they know that we're not using a speculum, which is that evil-looking contraption over on the right side of the slide. So the only time a speculum should actually even be used in a child that hasn't started to have her periods yet is if she's sedated, and if she has something like bleeding or if she has a foreign body in her vagina. But and speculum should never be used on a child who hasn't started her periods unless she's sedated. And unfortunately, there are some ERs around the state that try to treat little kids like adults and have used a speculum on those kids, and it's just wrong. It's bad medical care to do it that way. But so that's really one of the things we want to help people understand is it's really not an invasive exam. Yes, they have to be unclothed. Yes, we're going to look at their private part areas, but we're not actually going to do any kind of a scope inside, and we're not going to do a speculum. And so it's really not a painful, invasive exam. So if you have gone through puberty and started to have your cycles as a post-pubertal girl, we may or may not need to use a speculum. If it's uncomfortable and they can't tolerate it, then we wouldn't use it. We do let people know that we're going to photo document the exam findings and why. And then I try to make sure little kids know, especially, that we're not going to do any shots during their exam. Some of them may need to have blood work afterwards, but that's not what we're going to do as part of just the exam where we're looking at their private part areas. And that's when I introduce myself to a child, I'll usually say, "Hi, I'm Dr. Karen. It's my job to do a checkup today, make sure everything's okay on your body." And I'll let them know that I'm going to just check from head to toe and make sure everything is okay. And we'll let them know that we're also going to check their private part areas where they go to the bathroom and make sure that's okay as well. And they usually kind of look at me a little funny at that point. But we just really try to normalize the exam into checking their bodies and make sure that's okay. And try to get rid of as much anxiety as we can before they go into the exam for them to know they're not going to do shots and for their family to know that we're not going to do kind of a grown-up Pap Smear Exam on them. These are just a couple of example pictures of what photo documentation equipment can look like. The top right is what the system used to look like in our ER. The bottom left is the system in our clinic. And so you can tell it's not a small camera. You can definitely see it's there. So usually when we show it to kids and show that it just kind of magnifies things so we can see it better, most kids tolerate it fine. They're not necessarily scared or intimidated by it. They think it's kind of fun because we let them look at their ear or something like that on the screen. Occasionally we'll have kids that have been a part of a pornography event where they have had photos taken of them. And so if they voice that they are uncomfortable with it, then we will put it away and we'll just rely on drawings to do it. But we do try to photo document whenever we can just because it is the standard for the field nationally. So sorry for those of you that this is really basic review, but just wanted to spend just a couple of minutes talking about female, especially, anatomy, because that's a little bit more difficult to see than male genital anatomy. not because, again, we want you to do these exams, but because I want you to hopefully understand a little bit more of the why there's not usually physical findings. So to do the exams, and again, especially on girls, what we want to be able to see is really the opening to the vaginal area. So for young girls, that usually just means they can lay on their back and put the bottoms of their feet together and be in what we call a butterfly position, so it's pretty comfortable for them. We can keep them covered the best we can, except for just the area of being able to expose their private area. And then the labia are the big flaps of skin that kind of cover the opening to the vagina, and so we tell them that we have to kind of tug on the labia a little bit so that we can see kind of into that area where the vagina starts. So around the opening to the vagina is some skin called the hymen. So that's kind of our number one big cultural myth that we have to get rid of, is that a lot of people think that the hymen actually covers the vagina like a trapdoor, and it doesn't kind of open up until you either start to have your period or if you have some type of penetration. So what's on the diagram there is actually what you look like at birth. So even at birth, there is an opening to the vagina, and the hymen is more like a collar or a ring of skin that goes around the outside of the vagina. It's not a covering or a trapdoor. So even from infancy, you can actually penetrate into the vagina without necessarily breaking the hymen, because again, the hymen's like a collar. It's not a covering to that area. The other thing that's important to understand in this part of the body is that the skin in that part of your body is the same type of skin that's on the inside of your mouth. It's mucosal skin. So it's pink, stretchy, elastic. A lot can actually happen to that type of skin without really causing it to tear. If you can think when you've bit on the inside of your mouth before and your cheek can feel a little bit rough and rugged, it is injured, but it usually heals really quickly. It's uncommon to have to put kind of stitches into that type of an injury. So the same holds true for the skin down there, is that the hymen is actually very stretchy and very elastic. It can stretch and have stuff pass through it and into the vagina without tearing, but even if it does get a scratch or a tear, it'll heal very quickly, and it'll usually heal without any kind of scar left behind to see it. I've seen some kids that have had actually some pretty bad tears to their hymen when we've seen them right after an event has happened, and I can see them back in less than 2 weeks, and it has healed to the point that I wouldn't be able to tell they had a tear if I hadn't seen them at the first point. So those are, again, really important things, even if you're not a medical person, to kind of understand that even when injury happens down there, if you don't see it right away, then it can heal so where there's not any residual injury. And it's actually kind of difficult to injure that area down there. So when you hear, even if you're a non-medical person, when you hear that the exam was normal and that there was no findings, it doesn't at all mean that something didn't happen down there. It doesn't even mean that they weren't injured. It just means that what happened didn't leave any kind of physical residual behind. And that is probably what we spend the very most amount of time talking with families and investigators about, because if there are findings, and especially if there is DNA evidence, then those cases usually will plead and kind of move through pretty quickly. But for those of you that work in this field and you've heard a child give a very clear and credible disclosure in a forensic interview, or for those of you that are counselors and you've heard these kids kind of tell their story, but yet you know that they didn't have any medical findings, those are the cases that we really have to help people understand why that doesn't contradict each other. You can really have a normal exam even when sexual abuse has occurred, and even when that sexual abuse has involved penetration. So the other medical part to understand a little bit about is that the hymen in girls who have not started their periods yet, so if you're pre-puberty, the hymen is actually very sensitive to touch. And when we do these exams, we have to be careful not to touch the hymen, or it will make the child be uncomfortable and they won't want to cooperate with us anymore. So we'll have grasped the labia and kind of separated so we can see, but we have to be careful not to touch the hymen. So that means that if a child in a forensic interview has said, especially again if it's a child that hasn't gone through puberty, if the child says, it went in and it hurt, she is saying that something went and contacted against her hymen. She's not necessarily saying that something penetrated her vagina, but when we as adults hear somebody say it went in and it hurt, we jump to our adult understanding of facts and think that she's saying that she had vaginal intercourse. And again, with a prepubertal child who hasn't had sex on her own, she hasn't used a tampon, she doesn't really know the sensation of vaginal penetration. To her, she's basically saying that the labia was penetrated and something contacted her hymen. And in Arkansas and in most states in the Union, the only thing that they have to prove is that the labia was penetrated to call something rape. And so we spend a lot of time talking about the hymen and whether or not it's intact and whether or not it had injury. And it actually really is not that big of a deal because we don't have to prove that the hymen was penetrated. We just have to prove that the labia was penetrated. And oftentimes they can prove that off of the statement that they've given. And again, if you penetrate the labia and don't ever penetrate the vagina, well, of course the hymen's not going to be injured because nothing happened that would injure it. So it is a tough conversation to have sometimes with investigators and then in court as well, but a lot of it will have to do some with our own adult understanding of what the child is explaining kind of in their developmental framework. So this catchphrase of normal to be normal is really what I've been talking about, and that's the name of a journal article from back in the 90s that's one of the hallmark medical articles for our field because they started to look at kids that have been sexually abused with things like DNA evidence or they had an STD or that an event was witnessed, and they began to really understand that the majority of the kids, even with very proven sexual abuse, didn't have any clear-cut findings on their exams to show that they had had trauma. And so I think we've talked about most of these reasons already, that the mucosal skin is very stretchy and elastic. A lot can happen to it and not actually cause injury. When injury does occur in that area, it heals incredibly quickly. And then the child's kind of conversation about what penetration means versus our adult understanding of that. So when we do these medical exams, usually there's kind of three categories of findings that we would list on our report. Most of the exams are actually going to be normal or just be absent for findings. And so again, a normal exam doesn't mean they weren't sexually abused, it just means there's not any physical trauma left behind to see. There are some findings that can kind of happen in either case. So kids that are sexually abused can have these findings, or they can happen from other things. And probably one of the biggest things that falls into this category would be like genital warts. So that's caused by a virus that can be transmitted by sexual contact or by non-sexual contact. And we just can't really tell by looking at it on exam if it was something that happened from a sexual event or not. The clear evidence of trauma is actually pretty uncommon. So this is less than 10% of the cases that we see that they would actually have physical evidence to say that there was injury from sexual contact. This would be something like a tear of the hymen or a scar or something that was, again, kind of clear evidence, something that occurred. The other things that we would do is, if it is within that 72-hour time frame, we might collect the evidence collection kit. That actually gets submitted to the crime lab, and so we don't get results back on that from a medical standpoint. And then we would potentially do STD and pregnancy testing. And then one of the things that we try to do after we wrap up the exam with the family is really try to encourage them to follow through on an assessment for trauma-focused therapy as well. So the medical diagnosis, just for me, kind of working in a vacuum and not really knowing anything else, just looking at the medical findings, the medical diagnosis of sexual abuse would be that less than 10% of cases where there might be acute or healed injury, if there was sperm present, foreign DNA, pregnancy, but by far and away, the history is the most important aspect of these cases. I think for all of us that are medical providers, we have had a situation where we've getting ready to go in to do an exam, and an investigator has said, well, it's really going to depend on whether or not you see findings or not, because if there's no findings, then there's not anything that we'll be able to do with the case. And it's frustrating to kind of have a respectful but also very truthful reply and say, but, you know, if you rely on me to make your diagnosis of whether or not sexual abuse has occurred, you're going to miss 90% of the sexual abuse that's occurring in your community, because I'm only going to be able to tell in about 10% of the cases at a time. And I know that that's a complex issue, and sometimes that has to do with what the prosecutors feel like they can do in these cases when there's not physical evidence, but I think it is important for us to understand the truth of it, that actually the majority of the time there's not going to be physical evidence that sexual abuse has occurred. So after we've done the exam, I try to go over this actually a little bit with families even before we go in and say, it's not going to be surprising that we don't see anything, because oftentimes the family is really looking at us to try to understand if the child's telling the truth. Many of you are very familiar with the dynamics in these cases, that it may be a child that's made an allegation against mom's boyfriend, and so mom now has to decide whether or not she's going to believe her child, or if she's going to go ahead and let boyfriend stay in the home and think that the child is just trying to make something up. So it's very important for us to try to make sure that the family understands that even if we say good news, that there's no injury on the exam, that doesn't at all mean that the child is not telling the truth. And we have this conversation with every family, and I know from talking to our colleagues at CACs and other mental health providers that they'll have families show up and say, well, Dr. Farr said there was no findings, and so that means that she wasn't abused. So I can guarantee you I have not said that to anyone. So if they come into your CAC or your clinic and say that, then they're really fighting through their denial of trying to kind of figure out who they want to try to believe in the situation. So we'll go over this with really all the families, and then there's a statement on our medical report as well that will say the absence of physical findings in no way discounts the disclosure that abuse has occurred. So oftentimes as well, folks will ask, well, so if there's no findings, then does that mean it was just, maybe some fondling over the clothes, or, it can't be really sex if there weren't any findings. And so, again, folks really are using their idea of sexual intercourse from an adult standpoint as far as vaginal penetration or anal penetration. And that's, again, it's not actually a fair thing to do. That cultural myth that something has to pop or break or bleed, the cherry pop myth, is very pervasive, and it's even in the medical community as well. I have medical colleagues that think that something has to happen to the hymen the first time you have intercourse, and there's actually several studies of teenagers and young adults who reflect back on their first intercourse experience, and about half of them do say that they had bleeding, but half of them don't. And so there's really not any kind of trauma thing that has to happen when you have vaginal penetration. The best study that we have that we use from a court standpoint is a study that was done out of Texas, and they took 36 pregnant teenagers and did the photo documentation of their findings, and then showed them to people who didn't know the history of what had happened to the child. And in these 36 pregnant teenagers, so something had to have gone into the vagina at least once, if not more than once, for them to be pregnant. Only 2 of them had definitive findings of penetration. So even with that level of sexual contact, it's still not a given that there's going to be injury to the hymen. That study is hard to do in pre-pubertal kids who haven't started to have their periods yet, because we don't have that kind of gold standard finding to say that there had been vaginal penetration. But we do have several young kids that will test positive with things like gonorrhea and chlamydia. And so we know that there's been contact to the point that transmission of an STD has occurred. And actually the majority of those kids as well do not have any definitive evidence of physical injury, even though they've had contact to the point that it's left an STD. So that's kind of the look that I'll oftentimes get from a parent when I've kind of gone through all this with them about the normal findings don't mean that sexual abuse hasn't occurred. And so this is really kind of the point of trying to figure out from the family standpoint if they really are going to be protective of their child or not. And so if I still get that look after I've had kind of an in-depth conversation with them, then I may be trying to kind of figure out who's involved from a DHS standpoint to see if the child is really going to be protected. Because, obviously one of the worst things that can happen to these kids once they leave our clinics is if they go home and they're called a liar by their family, or if they're really pressured into recanting and those types of things, because it not only causes incredible stress for the child, but then makes it much more difficult for the investigation to have an outcome that would be favorable as far as trying to protect them as well. So there's actually quite a bit of literature out there as far as this normal to be normal phenomenon, and I've told you kind of the number in the literature is that only about 10% of kids who have been sexually abused, even including a history of penetration, will have findings of injury on exam. So there are some places in the state where I've heard that medical people will show up from the community and testify that there's no way that sexual abuse could have occurred without causing terrible damage. So if that happens in your area, feel free to tell your prosecutor to contact us, because there is just a wealth of published literature out there that person would need to be able to answer to on the stand to say why they would have a professional opinion that kids can't be sexually abused without having significant trauma left behind. So on the medical report, if we do have, so if it is one of those 10% of cases where we do have injury, I can tell you that there's injury, and I can tell you if it looks like it's acute or healed, but I'm not good at telling you the object that caused the trauma. So was it a finger or was it a penis? I'm not very good at saying that. And if it's healed, I can tell you that it's probably more than a week old, but it could be months old, it could be a year old. So that time frame on timing can be difficult as well. If there is trauma, I can't, if it is somebody that's old enough to have a consensual sexual relationship, I can't really tell the difference in consensual and non-consensual events, because some of the worst injury that we've seen in the ER has been from consensual events. And so just because it's injury doesn't necessarily mean it was non-consensual. If there's no evidence, we've already talked about this quite a bit, it doesn't mean that sexual abuse is ruled out, it doesn't mean the child's lying, and it doesn't mean that they aren't at risk for developing infection or pregnancy. So we would still test in those situations. So if they have a sexually transmitted infection, we're not going to spend just a ton of time on this, but if it is a young child that tests positive with chlamydia, it can be very difficult to kind of know how far back the child could have been exposed, because there are infections that can hang out and not really cause a lot of symptoms until they're tested. It's also not possible, even though folks expect it should be in our CSI and SVU world that we live in, we can't really take the child's chlamydia and then match it with any kind of DNA testing to their alleged offender. If the alleged offender tests positive, then it certainly does corroborate the child's disclosure that they both do have chlamydia. But if the alleged offender tests negative and the child has said that this is the person that did it, it doesn't necessarily mean the offender is not the offender. As we've talked about from a delay in disclosure, the alleged offender would have time to either clear the infection on their own if they have a healthy immune system. They can also go to the health department and get treated anonymously, and nobody would ever know that they used to have an infection. So trying to match these up when a child is positive can be a little bit complicated, but to understand that just because somebody tests negative doesn't mean that they couldn't be still the source of the child's abuse. Not going to spend, again, a ton of time on STDs. Probably the most common questions that we get on this is whether or not it can just kind of pass through the bathwater, or they can get it from sitting on a toilet seat, and really not. So gonorrhea, chlamydia, and trichomonas definitely all require intimate contact where the infected secretions are coming directly in contact with the area of body that gets infected. You can get these passed from birth, and so if it is an infant, then it is important to look at mom's history and figure out if it was passed by birth. But that's really not going to be a concern after the child's like a year of age. So beyond the report, I spend all this time kind of talking about the fact that a lot of times we can't tell, and so one of the questions I'll get asked is, so why do you do the exams if you usually can't tell? Well, obviously the first reason is that if they do have findings, we want to know about that, because that is important. And I think it is important to be able to go to court and explain the whole normal to be normal phenomenon. If a child has made a really clear disclosure of abuse and they don't have a medical exam, the defense is very good at using that to say, if everybody believed this child so much, why didn't they even refer him for a medical exam? So the lack of a medical exam can actually be hurtful in the whole investigative process. But the flip to that from a physician side is, I spend a lot of time talking with especially kids that are old enough to have the conversation, of telling them that I'm really sorry that something bad happened to them, and that unfortunately I can't take that away, but I think it is important for them to know that their bodies are okay. Many of these kids have very distorted body images because of the things that the offender has said to them over time to kind of keep them in their control, and so I think it's important to be able to let the kids know that even though they've been through something bad, that it has not ruined them from a physical standpoint, and that they can be kind of healthy and okay. So I also get quite a few questions when you do have a very supportive family that's really trying to figure out how to help their kid as they go forward from this. Is really asking, so what does this mean for my son or daughter long term? And I know there's a lot of people on this webinar that know more about this than I do, but I'll tell you, as I get to be their cheerleader at this point, because I kind of have them as a captive audience once we've done the medical exam, I really try to use this as a time to say, we've addressed the medical needs, and now the very best thing you can do for your son or daughter long term is to not only believe them, but also to try to allow them to have the opportunity to be assessed to see if they need trauma-focused therapy, because that is the number one thing, that if a child is protected and believed and is able to have access to the types of services that can help them, then that is those are the big dividing lines between who has the opportunity to really go forward and do okay from this. So we spend sometimes more time in the post-exam conference than we do just in the exam itself, again, explaining the findings, but then also trying to kind of figure out where the family is in all this. So do they believe? Are they protective? We try to screen them for some other things that may be causing family stress, like domestic violence, but then also, again, spend a lot of time trying to cheerlead them to take advantage of the services that are now widely available because of the great work ARBEST has done as far as having access to trauma-focused counselors around the state. And so then, lastly, depending on kind of how far we get in the conversation with the family and with an investigator as well, sometimes they will ask, so I don't really understand why they didn't tell me. Look, I'm their parent. They know that I would move heaven and earth for them, so why didn't they tell me that this was going on? And sometimes that's because they're trying to figure out if it's true, and sometimes it's just that the parent has so much guilt that this happened and they felt like they should have protected their child. And then investigators will sometimes ask, especially when they've watched the forensic interview, so why didn't they really show emotion? So if this was really something that was that bad, they should have kind of broke down and shown more emotion for that. So we already talked at the beginning that delay in disclosure is actually the norm. So it's for kids to disclose within the first 72 hours is actually uncommon. And we explained some of those dynamics already, that it's hard for kids to be able to disclose when it's somebody that they know, especially kids that are old enough to kind of know that their disclosure is going to hurt people's feelings, make people get in trouble, all those types of things. They're going to try to kind of hide it and figure out another way to deal with it without it coming out. This was a study that asked adults to reflect back on their childhood experiences, and about 9% of this group of 3,000 people described that they were raped in childhood. And then you can see the little bar graph over there on the side that only about 25% of those told within 24 hours. The other 25% was out to, anywhere from months to years, but then that other group, that kind of light pink, was more than 5 years. And within that group of the light pink, 28% of those had never disclosed until this telephone survey was done. So again, we are really only kind of dealing with the tip of the iceberg of the kids that we see, because there's actually quite a few people out there that are delaying disclosure and just never even disclosure at all. The disclosure process, there's some actually pretty compelling studies out there from medical exam and delay and disclosure standpoint too. This article by Schroberg, they actually took 10 kids who were videotaped as victims, and 3 out of those 10 kids actually denied that anything had happened, even when they were confronted with the fact that there was a video about it. So there's some really kind of compelling things out there that really do help us understand with the fact that the delay in disclosure is really the norm and not something that means that the child is lying. So this is good information to help with parents. A lot of parents feel like they have failed because their child, again, for those of you that work with these families, many of these parents have actually been victims themselves and never disclosed, and so then they feel, again, like a failure just because they thought that they would always be able to protect their child since they kind of knew what being a victim was all about. For the child, again, it's something that they may actually kind of believe for themselves that they are at fault because they didn't tell right away, and so they may start to have some self-blame off of those things as well. I spend a lot of time talking to especially investigators and judges and juries about the fact that, again, this delay in disclosure in no way means that that this is something that they should have said right away, or that they should have a certain kind of hatred or feeling towards the person that abused them. We try to, I think, put our own, kind of project some of our own expectations onto the child's response, and I think that can be a troublesome thing. This study by Nancy Kellogg and John Menard from Texas also really kind of showed us the importance of what happens from the parent side when kids disclose. So what does the mom do when the child discloses? Thankfully, over half of them do believe and protect, but about 20% don't, and the other 20% are kind of on the fence and just trying to really figure it out. So you know that that's a big thing for kids, because when they tell, if somebody doesn't believe, then they're probably not going to tell again because they didn't get a good response from that. And this same group kind of looked at kids that were having medical evaluations for sexual abuse, and they found that the average time to disclosure was 1.5 years. So again, that delay in disclosure was very much the norm. The other thing that they found in this group is that the highest rate of kids that will not disclose right away are those that are the ones that are willing to kind of accept self-blame for what happened. So if they have either told a little bit and then kind of been blamed for maybe making up a lie, then they will keep that inside and not continue to disclose and kind of tell everything that happened. And then the last kind of research stuff up here, just to have as a resource if you need it, is the why don't they show emotion? And so this was a study that looked at 124 different taped forensic interviews, and there was a grading system to kind of grade how much emotional response was being shown as they disclosed. So the majority of kids were actually graded as just being neutral during their disclosure, but the really interesting thing in this was that the number of abuse events that had occurred, so as severity of abuse went up, actually the amount of emotional response went down. And again, for probably people on this call, that's not necessarily surprising, because if that's just been happening to them and it is their norm and they've had to learn to survive that way, then they have normalized it to where they can talk about it without kind of necessarily breaking down and showing a ton of emotion. And again, this is not a 100% thing, but I think it is very helpful to be able to explain to folks that are trying to figure out if they do believe in this, that kids actually can describe what's happened to them without necessarily having some big emotional breakdown, especially when it's something that they've had to learn to cope and adapt with on a very regular basis. So that's my quick tour through the medical evaluation, and really kind of the two big take-home points would be the whole fact that there's not usually physical findings in these exams, and the fact that when kids do delay, it does kind of hinder the ability to find medical evidence, but that delay in disclosure is not something that would indicate that the child isn't telling the truth or that something hadn't happened. And so that's really, to me, one of the best part of this job. I know it's sometimes hard to say that there's a good part of working in the field of child abuse, but I think the things that we can all share from each other, from the mental health standpoint, advocates, medical, but I think we can hopefully all bring our own pieces of expertise into this so that the system can understand really what the kid has had to process through in this victimization, so that they can really kind of be understood from the standpoint of what they're saying in the forensic interview, but that we can also try to help families stay engaged to the point that they can kind of stick with the child and believe and protect them to the point that they keep them in for therapy longer term as well. I don't think we had any raised hands during the talk that I can tell, but please do, if you have some, I think we have a few minutes if you have some questions that you want to try to type in.
Yeah, go ahead and, if you're familiar, been on one of our webinars before, you can click on that chat bubble and type in your questions. And before we go to the slide with the CEU code, we'll just kind of hang out for a little bit and wait for questions to come in. I actually do have a question while people are typing is there like a referral list of like trained medical providers that have this specialty training that, you know, someone in White County or Arkansas County, that they would know whether or not their pediatrician or nurse has specialty training? Is there anything like that out there?
Probably the most reliable source would be if there is a medical provider at your local CAC. So the CACs of Arkansas have chosen to abide by the national standards, and so if there is a medical provider in a CAC of Arkansas, you can know that they have fulfilled the National Children's Alliance standards of basic training, continuing education, and photo documentation. Beyond that, there's probably some hit-and-miss pediatricians out there that know how to do the exams, but I'm not aware of anybody else that does photo documentation of the exams than the CACs and our clinic here at Children's Hospital. So here's the magic code.
And if folks are, watching this on a recorded YouTube channel, we only give out CUs for live presentation. So, but when you do send me an email, make sure you tell me your first and last name. And if you're watching this as a group, each person needs to email me individually. And if you weren't the person signed into the webinar, just let me know who was. So, I'll get your CU that way. But we'll hang out here for a few more minutes to take any questions from folks.
So come on, you got to at least tell us if like your fall colors are pretty in your part of the state or something like that. And I'll fill the silence a little bit and just say thank you. I saw kind of the list, a little bit of who was out there, and it was a varied list, and just say thank you to all of you that are out there working on behalf of these kids, and just kind of all the services that they need to try to address this.
Okay, we'll do a final call, hang out for like 30 seconds, and if questions come to mind later, feel free to email those to me and I can pass those along. But thank you all for joining us, and we'll just be on the line here for just a few more seconds, and we'll let you all finish your Monday. Hope everyone has a good Monday, and be sure to join us next month. I'll send out the email announcement about our next month's webinar here in a week or so. So y'all take care.